It's U of L Today on 93.9 The Ville. Here's your host, Mark Hebert.
And welcome to U of L Today with Mark Hebert on 93.9 The Ville. As most of you know, listen to this show either occasionally or all the time. This is a show about all things University of Louisville. We talk about research, we talk about programming. We often talk to students on this program. But today we're just going to talk to some faculty members at the University of Louisville about some things going on. So here's what we got on the show today. Kids who are abused and neglected deserve to have smart, caring adults overseeing their cases and an efficient system to track and treat them. So how can citizen review panels that look at child abuse cases be improved? And how can we better identify behavioral health needs of kids going into foster care? We'll have an expert from the Kent School of Social Work here to talk about it. But first, you saw the carnage at the mass murder and shooting in Las Vegas. 58 dead, 489 injured. Las Vegas area hospitals handled that number of casualties without needing any assistance from out-of-state healthcare providers. But what if something this terrible happened in Louisville, Kentucky? Could the University of Louisville Hospital and other local hospitals handle the number of casualties? Well, we're going to find out from Dr. Glen Franklin, who is a trauma surgeon at U of L Hospital, and hopefully he's here to answer those questions. Hi, Glen.
Thanks, Mark. Glad to be here.
Good to see you again. What'd you think when you saw the Las Vegas shooting?
Well,
in your profession.
Yeah, I mean, first and foremost, your heart goes out to the victims and to their families, and it's hard to believe something that devastating and that horrible can happen here in America. So your first sense is one of shock and just one of horror and sorrow.
Yeah, I think that's what we all felt. It's
I
the same feeling. It doesn't matter whether you're a doctor or journalist, whatever, you know.
But when you start thinking about it from my profession standpoint, then I actually know some of the surgeons in Las Vegas, so I start thinking about those guys and ladies and how they're going to handle this and how that many people could be transported to a limited number of facilities at any given time.
Right.
So your mind does start racing back to your own profession and what have we done to prepare, and are we prepared, and how would we take care of this type of an incident in Louisville?
Well, how would we take care of this thing and type of incident if it happened in Louisville, God forbid?
Well, we'd like to think that we do a good job. People tend to rise to the occasion in moments of tragedy, and we do have a disaster system here in the city of Louisville that involves police, EMS, firefighters, and the hospitals. There is a triage system of distributing mass casualties. Obviously, the University of Louisville Hospital is the level 1 trauma center. We're going to get the most seriously injured victims. In the Las Vegas incident, a lot of those folks were injured by trampling as they fled the scene. And so many of those folks could have been taken care of at other hospitals other than just the trauma center there at UNLV. And so you look for a system that tries to triage people appropriately to facilities that can handle their level of care. There were so many gunshot wounds that clearly many of them went to hospitals other than the trauma center, and so you have to look at ways of treating those folks as well.
But at U of L Hospital, say something like this happened in Louisville, and all the toughest cases, the worst injured, got sent to the University of Louisville Hospital. You know, I guess a lot of folks are saying, well, are there enough beds? You know, we keep hearing that University of Louisville Hospital is a small urban hospital. Yeah. Are there enough beds, surgeons, nurses, everybody else to handle that kind of situation?
Well, you ramp up, and we do have a disaster plan at the hospital. So the first thing that would happen would be you'd cancel all the elective OR cases for the day. And that's inconvenient to some, but in the face of a mass casualty situation like this, everyone would understand that you've got to take care of these people who are dying. We have a call system that would allow us to bring in additional nurses, additional doctors, support staff for the operating room. We do have an internal disaster plan that can be activated that brings folks in. And we have the ability to do some less than ideal, but certainly deal with the masses type of care. For instance, tents in the parking lot ways to triage people outside of the emergency room. Clearly, the emergency room, there's a bottleneck there, right? There's a door that ambulances drop off patients at. That's a bottleneck by definition. And we would triage people outside in the back parking lot, in the grass area. They can set up tents very quickly. Sometimes in these mass disasters, the issue is not getting people into the hospital. It's keeping people who don't need to be there out of the hospital. And there are plans for that with our security personnel to try and limit the traffic so that everyone who is there is essential to provide care to the people who need to be there for that.
When you talked about, that their triage on the scene is the training among the paramedics and others in Louisville is to triage them right there on the scene and figure out where they need to go. So I'm assuming that, they look at the injuries, they say, this one's in really bad shape. They need to go to University of Louisville Hospital. This one, not so bad. We can send them to Baptist East or Norton or wherever, right? Is that how that works?
That's how that works. Typically, our doors are open for all trauma, and we take all trauma from minor to major trauma. But in a mass casualty situation, the first responders, the EMS, the paramedics, they have a radio contact with the hospitals. They know what people can do and what they can't do, and they have a pretty good idea of where they can send folks around town. And really, all the hospitals will step up to their individual levels of capability. Years ago, during the Standard Reviewer shooting, victims were taken to 3 or 4 of the area hospitals. All the shooting victims were not operated on at University Hospital. Some were taken to Norton, some were taken to Jewish, as I remember. What worked about that day was it happened very early in the morning. So all the surgeons were already at the hospitals ready to start their normal operative days. And we have faculty from U of L at all of the downtown hospitals. And so even though you might not be at the trauma center, you might be getting operated on by someone who does a lot of trauma care because our faculty just happen to be deployed at all of the downtown hospitals. And a lot of these injuries can be taken care of by good surgeons, anywhere.
And you're a trauma surgeon, so you deal with gunshot wounds, I assume, all the time to come in the ER, right?
Nearly every day.
Nearly every day. Tell folks what it's like looking at a gunshot wound and the damage that a gunshot wound can cause. How do you describe that to someone who has never been in an operating room?
Well, on the outside, there's usually a hole that doesn't look very bad. And a lot of times you see on TV shows, you see blood coming out of the hole and people reaching in to pull the bullet out of the hole. That never occurs. That's just not what a real gunshot wound is like at all. In fact, many times we never retrieve the bullet because it's buried in soft tissue or muscle somewhere, and it'd cause more damage to pull it out than to leave it in. On the inside, bullets tumble. They don't always go in straight lines, and so you'll find holes in multiple things. If you think about your intestines being like a plate of spaghetti sitting in front of you, and if you were to take a very sharp knife or a poker of some type and go through that plate of spaghetti once or twice, you're going to cut a lot of spaghetti noodles. And that's really what your intestines would be like with a gunshot wound. And then there's all the solid organs that bleed, like your kidneys, your liver, your spleen, your heart. And those things can be devastating problems. And that's why, getting to the appropriate facility as quickly as possible is very important. Extremity gunshot wounds on your arms and legs, those can bleed quite a lot. And that's where the Stop the Bleed program comes in to try and get first responders or even bystanders to participate in stopping the hemorrhage, at least temporarily, till a healthcare provider can get there.
Nice segue into Stop the Bleed. I was just going to ask about that. What is the Stop the Bleed program, and how does it impact, or how could it potentially impact, bystanders and the average citizen?
Well, the Stop the Bleed program really grew out of one of the most publicized mass shooting events in America, the Sandy Hook Elementary School in Hartford, Connecticut. And so the Hartford Consensus began in 2013, shortly after the Sandy Hook event, to look at ways to minimize minimize death, but increase survivability from a active shooter event or other mass casualty event. Several national organizations were involved, including the National Security Council and the White House. The program came together under the auspices of the American College of Surgeons Committee on Trauma and the military, the Department of Defense. From this report, we learned that many people have survivable bleeding extremity wounds that bleed to death in the field because no one bothers to just hold pressure on the wound or to put a simple tourniquet on the leg or the arm to stop the bleed. And they came up with this statement that if you see something, do something. And just like the American Heart Association campaign for CPR, which is taught to lay people all over our country. In fact, my kid babysits some, and you teach teenage girls to do CPR to be, quote, a certified babysitter. And so the Stop the Bleed program takes the same concept to try and teach lay people to recognize a bleeding wound on an extremity, to hold deep pressure, and to try and put a tourniquet above that wound. And a tourniquet could be your belt, could be your shoelace, or we have
anything
kits.
You can tie tight.
That's right. We have kits we provide that have a professional tourniquet in it that you can get for $10.
Right. And so if someone wants to take the Stop the Bleed training, what do they do? Just pick up the phone and call somebody at U of L Hospital or U of L Medical School or what?
Yeah, they can call the University Hospital Trauma Institute. And we've been giving classes all over the community. To date, we've trained over 400 people in all aspects of life, from high school kids all the way up to the LMPD SWAT team. It's a 1-hour training program. We have some pretty crafty live models of bleeding mannequins.
Right.
And sometimes we can make it a competition. I did a fire department recently, and we had the two chief officers in the fire department raced on two of our mannequins to see who could stop the bleeding the quickest.
Fastest. Yeah, that's fine. All right. So that's a way that the average citizen, if we do have, again, God forbid, something really terrible, gunshots ring out in Louisville, Kentucky, and there's a mass casualty, something that you can do if you're on the scene right there, and also to show that Louisville is ready for one of these things, as Glenn just said. So there we go. Glenn, thanks for being on the program again. Good to see you.
Thanks again, Mark. I appreciate your interest and appreciate your audience's interest in something we can all do to help.
Well, there are thousands of well-intentioned adults trying to help kids who are abused or neglected. But like everything else in life, good intentions don't necessarily produce the best results if the system needs some improvement. Well, Crystal Collins-Camargo is an associate dean and professor in the Kent School of Social Work at the University of Louisville. She's been looking at citizen review panels set up to look at child abuse cases and also ways to more quickly identify mental health needs of children going into foster care. So those are two pretty interesting studies. Crystal, welcome to the show. Appreciate you being on. All right, let's talk a little bit about the citizen review panels first. You have taken, first of all, I guess we ought to say, what's a citizen review panel and who set them up and why do we have them?
Sure. So for about 20 years, the federal government has required state child protection agencies to have these citizen review panels. The purpose is really probably multiple-fold. Partially to look at the system and make recommendations from the outside in terms of how the system could work better to serve families and kids. Also, getting volunteers from the community involved helps build advocacy for that system and awareness in terms of how it works. So they've been in place for a long time, and each state is required to have 1 to 3. And one thing that we've just not been able to really figure out is how can we really get those local folks engaged and willing to keep on doing this when they're really not looking at specific kids and their situation, they're looking at the broad system as a whole, which is less, kind of hits your heart, I think, a little bit less directly.
Right. Not as emotional because you're not talking about the 6-year-old who was abused by mom or dad and to see whether that case was handled correctly. But these folks just look at the system broadly, right?
Right.
So is the problem that they're looking at bureaucratic processes and they're not quite as engaged? Is that the...
I think that that's part of it. They're looking at really the practice side. They may be looking at outcomes for kids and families, but the federal mandate is for them to look at the extent to which the agency is meeting federal requirements in terms of doing the job the right way, meeting those kind of statutory practice standards.
Right.
And so it feels a little bit detached. And if you can imagine that, you are just your average citizen, maybe you're Mark Hebert working for the University of Louisville, you really don't know anything about, how this should work. And so it can seem very overwhelming. And although we have people who work for other human service association or organizations, associations, advocacy groups that know something about the system, we also have a lot of folks that work at the grocery store or are a nurse or whatever. And so really understanding how can they really make an impact on the system, I think, is a disconnect.
Right. We're talking with Crystal Collins-Camargo from the Kent School of Social Work at the University of Louisville. What have you done then in terms of research to try and figure out how these people are engaging or not engaging in the process of dealing with these child abuse and neglect cases?
Well, we've done a series of studies over the past several years to try to get to the perceptions of people in key roles. A couple of years ago, we surveyed public child welfare administrators from the bureaucratic agency. What do they think about these citizen groups looking at their agency and making recommendations from the outside? Somewhat surprisingly, the results of that demonstrated that they saw it was a real positive potential. This most recent study looked at the perceptions of those volunteers across the country and how engaged they feel, how impactful they are. And what we saw there is they're really sort of moderate in terms of feeling like they're prepared and they're really making a difference. And I think we did gain some insight in terms of what agencies might do to better get them up to speed and keep them engaged so that they keep on doing that work.
Does it vary from state to state? Because, like in Kentucky, there's been a lot of focus on the way the foster care system works, the way Child Protective Services works, and if you've got residents who are supposed to look at the whole system and say, well, that's not working, and they're not following the state law on this, the state isn't following their own laws and regulations, that if there's a focus and an eye, you might have people that are more engaged that are average citizens, whereas in another state where things seem to be running smoothly, there's not any terrible cases of child abuse that were left unattended in the newspapers in that state, then maybe they aren't quite as engaged. Can it vary from state to state like that or not?
It may. I think that there's a lot of reasons why it varies, and some of it may be that in terms of how much the public is concerned about how the system is doing. I think you're going to have more people step up and want to do this if there's a lot of concern about what's happening. If that's not the case and there's not been a lot of scandal, then a different approach to marketing, because it's just as important, really. All of these systems struggle with doing this really difficult work.
Right.
So we need, it's a really tough job, probably one of the most tough there is.
I wouldn't do it.
Yeah, well, I did do it a long time ago,
did you really?
And I don't want to do it anymore. I like being supportive on this side of things from the university.
Right.
So I do think that sort of thing varies, and the other piece I think is the way that the public agency views and either embraces or does not embrace the panel and really just meets the requirement because the feds say they have to. And so I think that that's another big piece.
We're talking about citizens that are on these citizen review panels, basically. But you just said you were in the system. Were you a social worker that deal with Child Protective Services and those kinds of things?
Yes. Many years ago, I was a frontline social worker that did child abuse investigations. Then I was a supervisor and an administrator, all before coming to academia.
Well, have these oversight committees of citizens made any difference from your point of view in the way the system operates and the way cases are handled and followed up on?
I think absolutely they have. And I think part of what's difficult is to know from that side of things, as a panel member, really what impact have you had? Because your panel makes a recommendation. It may be down the road before it can actually be realized. Funding is needed, or major change is needed, or there's just not good communication. I've seen many examples in Kentucky and elsewhere where this sort of panel can make a difference in terms of recommending change or even supporting the agency as they try to change. And I think to me that's in some ways even more important, where you have these citizen groups that are saying, hey, legislature, these folks really need this additional support.
Right. The other thing that was kind of interesting, by the way, we're talking to Crystal Collins-Camargo from the Kent School of Social Work at the University of Louisville. The other thing that I thought was interesting in part of your research was that the states who had contracted with universities had some different outcomes than those who didn't, correct?
Actually, they did not have different outcomes, and that was what I found most interesting. Most states contract with another entity to facilitate the work of the panel, basically provide staff support, help them get the information they need to review, that sort of thing. One of the models that many states use is contracting with universities. Other states go with another public entity like the court system, and they facilitate the panel, or maybe they contract with a nonprofit. And so one of the things that we wanted to look at was, are there any differences in those university-based contracts for facilitating this? And the panel members that were from those states where the university was doing that work were no more knowledgeable, no more engaged, and felt no more confident in impact than the others, which was a little disappointing. But to me what that suggests is that if states are going to choose a university, they need to build that contract to maximize what the university can bring to them. And if the contract is really just provide the staff support and whatever, then it makes sense that there'd be no difference. If the contract is
to train these
to
citizens.
use our expertise in education and our expertise in facilitating collaborative work and our expertise in research and evaluation to help the panel get even better data, then I would hope that the outcomes would be different. So I think that that's an important next step.
Where's Kentucky land on this? Do they have a contract with either UK or
They
U
do.
of L? Or,
They contract with UK and have since the original mandate came down.
Okay.
So UK College of Social Work has had that contract for all that time.
Okay. All right. So hopefully they're the state of Kentucky is using them appropriately and using them for the good and not just spending money that's kind of wasted.
Right.
Okay.
Right.
All right. Let's talk about another project that you're working on. You're trying to figure out a way to better assess kids and their mental health needs before they go into foster care, or to grab them early, correct?
When they first go in, right? When they immediately come into foster care, yes.
Well, how's it done now?
Up until this project, kids will come into foster care because they've been abused or neglected, typically, which we would expect would be very traumatizing. But many times the primary focus in terms of the child is finding them a place to live, making sure that they're in school and sort of that day-to-day care. And then the system focuses on how do we help the family fix whatever was going on that caused the child to go in to care. And the child may or may not be referred for behavioral health services at that time. And generally, until they start really acting out and showing what the impact the placement and everything else has had on them, they may not get referred. But we know that those kids that may be much more quiet about how they're feeling still need that assessment. So the idea was to try to assess for that right at the beginning and hopefully get those kids into treatment if they need it from the beginning so that they can better adjust to their placement so that their outcomes would be better.
I would think that would be really tough on foster parents because really, God bless them for being foster parents, number one. But secondly, that you're getting kids that you really don't have a lot of knowledge about their background. And the kid walks in the door, and 2 weeks later he's acting up and acting out and, throwing stuff in the house and being violent. You prefer that there be an assessment before they walk into your house, right?
Right. I mean, that's an excellent point because it really is a... You're going into it with very little information on what that child's needs are, what they've been through. And so that's really another side benefit of this, because by using standardized tools to screen for trauma and behavioral health needs, we can share what we've learned with that foster parent, get them involved in treatment if it's necessary early on, and help them provide the right kind of care.
Right.
The way that you parent your own child may not be the way that you need to parent this foster child who's come from a very different kind of experience. And so I think this provides an opportunity in that way as well.
We're talking with Crystal Collins-Camargo from the Kent School of Social Work at the University of Louisville. On that, what is being done now? Don't you have a pilot project going on in different areas of the state to try and grab these kids and get them into a mental health assessment quickly, right?
Yes. We are entering our 5th and final year of this project. So as of November 1st, we will be implementing this project in 7 of the 9 regions in the state of Kentucky. And what that implementation involves is the child welfare worker uses standardized screening instruments within the first few days of the child coming into care to determine whether or not they should be sent to a behavioral health agency for assessment. If they are, then that behavioral health agency, regardless of whether it's a community mental health center or a private therapist or whoever it is, will use a standardized instrument as a part of their clinical assessment to determine if treatment is needed, what sort of evidence-based treatment should be provided, and then use that same tool every 90 days to measure progress for the child.
So, and how many kids are we talking about in those? Well, how many foster kids are going into the system each year in Kentucky?
We
Any
have about
idea?
8,000.
8,000?
Yeah.
Wow.
So
I had no idea, to be honest, that was that big of a number. So are we talking about assessing each one of those 8,000 kids before they go into the foster care system?
well, when they come in. So
When they come in,
within those
right.
first few days when they come in.
But
Now,
before they get placed.
But no, I mean, usually they're in placement
Okay.
before this happens.
Okay.
We would have to, it's not the kind of situation where the worker sort of goes to the hospital or whatever and does this.
Right.
The primary focus is getting that child to a safe and stable place first, but within that first 10 days to do this.
I got you.
So, yes, I mean, it's a huge volume once this is fully rolled out. Now, we're only doing it now as kids come in, not the kids who've already been there.
Right.
But gradually, you know, as this has been implemented for more of a time period, then we would have, you know, thousands of kids around the state that would have had that.
Right. And the benefit is what? What quickly?
The benefit is early identification of needs, selecting evidence-based treatments so that those kids are able to work through the emotional impact of what they've experienced and have improved outcomes. They're more stable in their homes, they're functioning better at school and at play, and hopefully in the long term will have better well-being.
All right. Well, Crystal Collins-Camargo, thank you for your work with kids and for the work that the Kent School of Social Work is doing. Thanks for listening to U of L Today with Mark Hebert, and go Cards.